you can see that for most of a woman's reproductive life, where we're bathed in a sufficient amount of estrogen, we have a ideal pH, which is conducive to the good bacteria, the healthy bacteria being present. We have a thickened and epithelial lining of our vagina. We have adequate lubrication, and that all provides a vagina that doesn't typically hurt. That is, we're able to have vaginal penetration with intercourse without having pain or difficulty doing so. And then when we go through the menopause transition and we are not making as much estrogen, nearly as much as we were during the reproductive years, we see a lot of changes. And this cartoon kind of, I think, does a good job of showing that, how the thickness of the vaginal tissue decreases, the lining becomes what we would call atrophic, so it's paler, it's thinner, it's more prone to injury. And all of this can result in pain during intercourse, irritation just in the day-to-day activities like walking, using toilet paper, and lead to difficulties with incontinence, and sometimes even worse or more pronounced issues like uterine prolapse. So we're going to talk about some of those issues tonight, because I think this is something that we don't talk about. We hear about hot flashes and we hear about osteoporosis, but this in particular is not something that women share, but this is so treatable and in some ways preventable. When a woman has complaints of vaginal dryness and pain during intercourse, one of the things that we talk about is making sure that we have adequate lubrication. There are over-the-counter lubricants that can be categorized as water-based, silicone-based, and then there are natural oils. And there also are products that we clump into the category of vaginal moisturizers. Replens is a popular one that many patients find beneficial. And when those aren't providing adequate lubrication, there are medications that require a prescription, and many of them are hormonal, such as estrogen tablets, estrogen creams. There are rings. There is a new product that is an oral medication that is an estrogen receptor modulator that, although you take it orally, binds to vaginal tissue and has a stimulating effect on the vaginal tissue. And so those products can be very helpful and effective. Tonight, though, I want to utilize our experts here to talk about some of the other treatments that can be used in conjunction with traditional treatment like estrogens, instead of or together with. So Terri, when a patient is referred to you with vaginal discomfort and painful intercourse, I think a lot of patients that I suggest seeking pelvic floor physical therapy, they're like, that sounds weird. What is that going to mean? How does it work? Can you walk us through what an experience might be when you first meet a patient, how you evaluate her, and then what are some general options that might be beneficial for a patient like that?
So the first time that someone comes into the clinic, the first thing that we have them do is fill out history. So we have some of the history that we can already look up, in their medical record, but we have them fill out a history form. That gives us a bigger picture of exactly what's going on with them. So in there, we ask a lot of different, questions about like their sexual health, if they have partners, and, if they've had any births, those type of things are in our health, our medical record. So we ask them to fill that out. Then we bring them back to the room and we sit down and talk. So I know a lot of people are so nervous. They call us and say, what is this going to be? What do I need to wear? Just be yourself. Just, bring yourself. We go back to the room. We talk about things first. So we'll get more by what they fill out on that paper. We ask more of a history. So then we start to ask questions to try to put the pieces of the puzzle together. Then we explain to them exactly what we're going to be looking at. So as a physical therapist, we, obviously look at bones. So we look at their posture, we look at their alignment, we look at their range of motion. So range of motion is really important. So that you think you're coming in for pain in the vaginal area, but we're having you do, lumbar flexion, lumbar extension, lumbar range of motion, hip range of motion, all of those things, because it does affect the pelvic floor. It's all attached to the pelvis. So we need to take a look at that as well. And then what we do is we take a look at the strength of your extremities and get a baseline there. And if we see anything that's off, then we can dig a little bit further into that and see if there are postural issues that we need to address as well. Then we step out of the room and we let you get undressed, usually from the waist down, get up on the table. And then when we come back in, we discuss, we explain even further what we're going to be doing. And before we do that, we do always, and I have it in my lap here, we always bring out the pelvis and explain, what it is that the pelvic floor is. So we do that first. And then we'll talk about exactly what we're going to be looking at. So first of all, we look externally to see what's going on externally. So after we've done all the postural stuff, now we're going to get in there and palpate. So we palpate, usually we look at from the rib cage to the knees. So we're not only looking at just palpating everything, but also watching how the person is breathing as well, because that's a big part of pain management, is being able to relax, being able to let that go. So then we'll palpate abdomen, and then we'll go down to the pelvic floor. And we usually start like around the sits bone, so the bone that you sit on. So if it's this way, you're sitting on it. We'll come up the pelvic floor in the front, the anterior portion of it, or the front part. If there's any areas that there's, stating that there's pain, then that's something else that we need to look in a little bit further. Is it the deep pelvic floor? Is it more external pain that they're having or that you're having? And then what we'll do is we'll do an internal examination. And that's done just without a speculum. It's just one finger, gloved finger, and then going in vaginally and looking at how that tissue feels. What do the muscles feel like? And then we also check the strength. So we'll have you do a Kegel, see how you engage those muscles and how do those muscles relax. After we do all of that, then we step out of the room, let you get dressed again, and then we come back in and we talk about what we found. And usually as we're doing it, we're talking as well. But then we come up with the plan of care. And then from there, we set up the appointments and establish that plan of care and do that plan of care.
And every patient is so different, but for a 60-year-old woman who may have had two vaginal births, who is 10 years into menopause and is having very painful intercourse, what are some things that you might see on that exam that then you would focus your efforts on?
So one of the big things, like I said before, was that breathing. So if somebody has pain in the vaginal area, we have a tendency to tighten down around it. So the analogy I give is if you have something wrong with your neck and you have neck pain, you can't just turn your head like this. Okay, we tighten up and we turn our head to look. So the same thing happens here. So our body locks down around this area. So we have a lot of tightness and a lot of lack of movement that we need to restore. So what we're looking at is palpating those muscles and feeling what is the tension and teaching the patient how to get those muscles to relax. So as soon as you decide you want to have intercourse and you know it hurts, you're going to be tightening up. Mm-hmm. So what we'll do is we'll teach you how to do some relaxation techniques to get those muscles to relax so that you can have penetration. We also talk a lot, like you said before, about lubrication, positions, sexual positions that will make it more comfortable for penetration and make it more pleasurable for intercourse. So we talk a lot about, mostly about that relaxation, and things that we do for that are, we do manual massage, and then we teach, and I was showing them before we started some massage. I don't know if you could see it there, it's clear. Massage wands that we can teach you how to do the massage yourself, so that in between therapy sessions, you just come in and then you're starting to feel really good when you leave, and you go home, and a day or two later, things starting to tighten up again. So this way you can manage some of this on your own and be able to do that massage. And we teach you how to use this. This is a typical massage wand. One end is pointed, one end is rounded. So you can use it externally and you can use it internally. And we do all of the education in how to do that massage. Another thing that we do is we invite partners in. So we would, during that first therapy session, we always say, if the partner wants to come along, by all means, have them come in and see what we're doing so that they can learn. And we've taught them also how to do the massage, abdomen and the pelvic floor, and also some internal stuff so that they can help before you try to have intercourse to get those muscles to relax and make it more pleasurable.
It's incredible how much can be done really without medications to really improve some of the and restore sexual function.
Absolutely.
So just switching gears a little bit, because what we've been talking about is painful intercourse, and that's related to menopause. But another problem that you probably encounter a lot in your practice is incontinence. So I was hoping, a lot of us have heard of Kegels and the benefits of them, but I was hoping that you might talk a little bit about that exercise, how to do it, and whether some of that can be done preventatively for patients who are just entering midlife.
So usually the first line of defense is to send them to us for physical therapy. Just like any other injury that you have, you come in to work on strengthening. You can strengthen those pelvic floor muscles. Those pelvic floor muscles sit at the base of the pelvis and they form a hammock. It's what we call it, the hammock down here. And if those muscles are weak, they're not giving support to everything that's above it. And that's when you start to get issues with urination, with your bowels. All of those things are affected by the strength of those muscles. So a very easy exercise that you can do is the Kegel exercise, and that's contracting those pelvic floor muscles to strengthen them and also to increase the endurance so that you're able to hold that until you can get to a bathroom. So the way that you do that, so a lot of people do a Kegel incorrectly, and that's what's important about coming in for physical therapy, so that you can learn how to properly engage those muscles. So if these are your pelvic floor muscles, we need you to engage those muscles. A lot of times when I ask a patient to do a Kegel exercise who say they've been doing it for years, when I watch them do it, I see this. So they're going up and down in their chair or their stomach, they're engaging their abdominals. And when you do a Kegel properly, you shouldn't see any of this movement. So what you're doing is you're engaging that pelvic floor, lifting, squeezing and lifting the pelvic floor, and only the pelvic floor, to be able to isolate it to increase the strength. So the way that we do that is we use biofeedback in our clinic. And that biofeedback, I'll just show you how we connect to it. It's a biofeedback unit that has a screen on it that our patients can see how they are doing and how they're progressing with that strength of the pelvic floor or engagement of those muscles. So this is one of the things that we use. This is a vaginal probe. So if someone has a very weak pelvic floor, we will opt to use the vaginal probe, There's a smaller size other than this, but we opt to use this. The reason is because this also has electrodes on it. Try to see that better. It has electrodes on it so that we can actually put electrical stimulation in it to be able to teach you how to engage those pelvic floor muscles. So somebody that has leakage that just comes through their clothing, they can't engage those muscles. We can use this vaginal probe to, one, see, are they getting any contraction, and also to send that stim through there to be able to get that contraction and teach them how to do it. The other option that we have is if someone is a little bit stronger with their pelvic floor muscles, we can use just these external electrodes, and we stick them right next to the anus, and that is where those deep pelvic floor muscles are closest to the surface of the skin. So we get a better feedback of what those muscles are actually doing. So a lot of times people say, why are you putting the dots here if it's my pelvic floor? Well, that's where they're most accessible and they're closest to the surface of the skin. So we put those 2 dots right here. And then what we ask the patient to do, or ask you to do, is to bring those 2 dots together. So if you can bring those 2 dots together, you're doing a proper Kegel without those dots rising up and down, which means you're probably using your glutes, or without them rolling, which you're using your abdominals. So it's all a matter of teaching you how to properly engage these muscles. Then when you're near time for discharge, there's a couple things that we recommend for our patients to get. And this is a home biofeedback unit. This is the actual probe. It goes in vaginally, and they come in all different shapes and sizes. And they range anywhere from like $49 to like $200 is the different units. So this piece goes in vaginally. This piece doesn't matter where it is, but this connects to your phone. So it's a Bluetooth connection. So you can watch on your phone or on your computer how you're engaging those pelvic floor muscles. So this way, because doing Kegels is something that you're going to be doing lifelong, this will help you to be able to keep track of it, how often you're doing them, and also what your strength is like. Are you improving? If not, what do we need to do other than that? But we always do this as a home program and encourage our patients to get that home biofeedback unit. The other thing that you can do is you can purchase weights. So this is a vaginal weight, and these range in size. This is very, very light, and then it goes up to this one that's pretty heavy. Okay, and these go in vaginally. They're put in vaginally, and then you do your exercises with that in, just like you'd go to the gym and lift weights, with your other muscles. Same thing that we can do with those vaginal muscles is use these weights to increase the strength of those pelvic floor muscles.
Now, it's so cool that these products exist. If listeners at home are thinking that they want to just buy one of those products and start, what do you think about that idea?
So it's fine to do that. I would recommend that you get a therapist at least for one session to come in so that we could teach you how to properly use the unit, or to properly put the weights in. It would be beneficial if you came in at least to do that education, but you can purchase them at home. And again, like I said, they're all different ones. The most popular ones are like the Parafit. You see that a lot now on if you're on Facebook and stuff, you'll see ads pop up for Parafit. This particular unit, and the majority of them have games that you could do too. So it's pretty neat. So it's like a gaming system, so that it makes it a little bit more fun than just sitting there doing the basic Kegel exercises, your quick flicks and your long holds. You'll have some games that you can do as well, and it will monitor your progress in those games.
That's so cool.
And as you achieve a level, you go up to the next level on most of those games. So getting a unit at home is fine to do, but if you have any questions about it, then you need to, seek out the physical therapist to be able to help you understand it if you're having issues with the use of the home unit.
So very often when a patient is diagnosed with incontinence, first they would have had an evaluation by a urogynecologist like Dr. Hudson. Dr. Hudson, can you walk us through what a typical patient coming to you who's complaining of leaking urine or, having wet underwear by the end of the day, what does that evaluation look like? And then what are some treatment options for that patient?
Sure. So a typical new patient visit for me also includes filling out some extra paperwork. So we can get some information about questionnaires, how much, what's been going on, how much it bothers them, how much it's affecting their quality of life. Because almost everything that I do is quality of life. So, I have patients who leak urine, but that doesn't bother them, so those are not patients where we're going to change that. Right. So getting a sense of what actually is bothering them is very important. My nurses will take a urine sample to make sure there's not an infection or something that might be causing some of those symptoms. They'll also do a test where they scan with an ultrasound to make sure they're emptying their bladders completely. And then they get them in a room. I come in, I talk to them first, kind of get a sense of what's going on. And then I step out, let them undress so that I too can do a very similar exam to what you described.
And after the exam, are there any tests or procedures that you would do in the office to help delineate what might be the issue?
So a lot of times I really don't need any additional tests to know what's going on. A lot of it can be done based on the history and what I see on exam. If I have someone that I'm not sure what's causing the leakage to happen and I haven't been able to get them to leak on exam, sometimes I'll actually fill their bladder up. I do a really simple test where I take a very small catheter and I put it into the bladder. And then I start to fill their bladder with water to see, and that tells me a lot of things. It tells me when they can feel that there's something in their bladder, how much their bladder can hold, if it's that the bladder is squeezing and that's what's causing them to leak, or whether it's stress incontinence where they're leaking with coughing or laughing or sneezing. So I try to reproduce that so that I can better address what's going on.
And can you explain just briefly what the different types of incontinence are?
Sure. So the most common things that I see when a woman comes to me for leakage of urine are for either stress incontinence, and that's the leakage with coughing or laughing or sneezing. What's usually happening there is that the urethra that joins the bladder to the outside is moving too much. It has this hypermobility. And so when they cough or laugh or sneeze, they leak. And so a lot of the treatment is kind of building up that support under the urethra, whether that's with pelvic floor muscle exercises, or even there are some incontinence devices that you can use, or there are more procedural things that can help with that. Whereas the other type of leakage goes along more with urgency. So you get an urge, you can't get to the bathroom in time. And what tends to happen there is that the bladder is irritable, it's squeezing. So there are, rather than focusing on the support of the urethra, that's where you get into there are behavioral things that can be helpful. There are the different ways that you can use your pelvic floor muscles for urge suppression. There are more medication type things that we can talk about, or there are even some other treatments down the line.
Why do women who are menopausal tend to have these issues more than a 30-year-old?
Sure. And some of it is that over time, you'll kind of see this progression. So a lot of my younger patients will often be complaining of stress incontinence. And as they kind of move forward, it transitions more into, not always, but more commonly, it's more urgency incontinence or overactive bladder. And some of that may be because this, as you go through menopause, the estrogen goes down, things get a lot thinner. And there's also some loss in kind of the strength of the pelvic floor muscles. So some of that protection that they may have been having goes away over time.
Is this an uncommon issue to affect menopausal women?
So what I will tell my patients is if I take every woman between the ages of 60 and 80, over half of them will have some type of urinary incontinence. So it is something that a lot of people don't talk about, but it is extremely common. And it is not considered to be a normal part of the aging process.
I'm glad you said that. And I see Terri shaking her head. I think so many midlife issues, but particularly this one, we just assume it's rite of passage, getting older. But what
have to wear the pads, have to wear the briefs, but they don't have to.
Right.
No.
And so I'm glad that you said that. And what I also hear you saying that I wanted to emphasize is that unlike other menopausal issues that can get better or rebound, this one typically does not. It's progressive.
Well, and I think that if you are doing something that works for you, that helps it, it does not necessarily mean you're going to end up with a surgery. Because people will ask me, well, if I do pelvic floor physical therapy, is it just going to get worse over time? Well, a lot of it has to do with your buy-in. Are you doing those exercises? Are you continuing the teaching that they've taught you over time?
Very interesting. So after a typical, and I'm making a lot of generalizations here, but Dr. Hudson, after a surgery, is there a role for follow-up physical therapy?
So from looking at the studies, we've never been able to show that it helps. But patients who ask me that, I mean, everybody should go to see a pelvic floor physical therapist. And I'm not saying that just because we're on the line with one, but I think there's so much more that they do rather than just, it's not just about strengthening the muscles. There's a lot of teaching that goes in on how you use those muscles and how you should be voiding properly and having bowel movements properly and breathing and all of those things. So anytime anyone says, well, I've been thinking about pelvic floor physical therapy, do you think there's a role? Can it help? Absolutely. Especially if you've got a really good physical therapist.
Yeah.
Definitely before surgery would be good to strengthen those muscles before it. And then after, exact same thing is getting them to relearn how to engage them if they haven't been engaging them for a few weeks and they're fearful of doing that for fear they're going to mess up their surgery. Getting them back in and just reintroducing all of that again and how to engage it is, I think, important.
Absolutely.
We do a lot of education on like toileting posture and bladder irritants and a lot of those things and techniques that they can use to decrease the urgency. So there's many things that we can teach them as well because we have the time. And we do see our patients for an hour. So we have a whole hour to work with them. Usually it's once a week, but we have that whole hour to be able to focus on them and educate them.
And one thing that patients may not realize is that this is not physical therapy that you are doing in a big room.
Correct. I should have said that too. You're right. They're private rooms that we have. And again, the only time that we would take them out into the gym areas when we're starting to work on core and really working on that core stability, we may go into a gym area, or if they're having leakage when they're running and we need to get them on the treadmill to do some of that, that's the only time we would go out into the gym, but they're fully clothed, obviously, when we go out there.
I'm glad that you mentioned that.
That was good. People probably do think that.
Yeah. Okay, so we talked a little bit about incontinence as a not uncommon issue that can affect midlife women. we talked about dyspareunia or painful intercourse that happens often as a result of low estrogen causing vaginal dryness. But then what I often see is initially that dryness causes painful intercourse. And then it's common to then clench those muscles because you're anticipating it might hurt with the next encounter. And then that seems to set off this cascade of now a muscular part of their pain.
So then they're like, I don't come near me. You know, that their spouse wants to still be intimate and they're, you know, tightening up. So we teach them different breathing techniques and ways to relax that pelvic floor. And they get to, what's neat is they get to see it on the biofeedback. So they see how the tension, that resting tension of the muscles and how they can affect that. So it's not that they're getting a medication, they're not, it's how can they physically be able to allow those muscles to relax so that they can be intimate.
Which is such an important piece of it because low libido is a very common complaint that my patients will talk about. And the first question I have is, well, does it hurt when you're intimate? And very often the answer is yes. And it would be normal to have a lower sexual desire if it was painful. And you know, it's a little bit like PTSD. You're anticipating it's going to hurt.
So then you tighten up.
And then you tighten up. And even if on some level you're aware of this, I think it's hard to retrain those muscles without having some of the biofeedback that a therapy session can offer.
And just palpating with us, just getting in there and just getting them to feel it when they engage and relax those muscles is very helpful. So a tactile kind of cue to them is very helpful.
So we have evidence that when a couple can remain intimate twice a week would be a goal, that quality of life is improved and most major health parameters increase. So it's, you know, that might seem like a lot, but that would be a goal. And would you say that is, from the patients that you're seeing, do you feel like that's an achievable goal?
Definitely. It's definitely achievable if they take the steps in between. So if they just go by what we do when they're there in the therapy session, it's short-lived. But if they can take these things and apply it at home, and especially bringing the partner in, you know, they don't have to participate if they don't want to, you know, hands-on. But if they at least understand what their partner's going through, I think that's a big help as well. So that the patient is not feeling like, oh my gosh, I'm like disappointing him, you know, and stuff. I want to be able to do things, and this way he could see, here's why. Do you want to feel these muscles and see what they feel like? So that, and this is what you need to do to help them to relax so that you can get to that part of the intimacy.
Yeah, that's a great idea. I do think that for a lot of patients, they're missing the intimacy part, but even more profound is they're feeling that they're disappointing their partner.
Yes.
So that's great that they could also be involved and be educated. Any other tools that you think? You probably can't see it here, but Terri has a whole goodie bag of things. And any audience members that have any questions, please share them. We have two amazing experts here to answer any pelvic floor questions. One question that has come in is, what could be a cause of not completely emptying your bladder if urine trickles out after you feel like you've emptied? Dr. Hudson, is all you.
Most often when patients say that, their bladder is actually completely emptying. It's more this kind of after spasm that happens that in my mind, tends to go most frequently along with overactive bladder, that frequency and urgency. It can also be stress incontinence, but I feel like it's usually that that bladder is contracting.
And in that patient, do you think that urodynamics or additional testing would be helpful, or?
I actually rarely need to use urodynamics for urinary incontinence, and will leave it for people who have, if they've had a prior incontinence procedure or we've tried a couple of things and they're not getting better. But the vast majority of people, you can find out what's going on without some of that more invasive testing.
Okay, so audience at home, it doesn't necessarily mean that you'll have to go through some additional procedures, right, Dr. Hudson? Sometimes
That's
an
correct.
exam can be helpful to know the best way to help you.
We talk about this a lot when we're doing our education as well. So we teach our patients that double void to be able to make sure that they're fully emptying. And what we explain too is when those pelvic floor muscles, if they're not strong and they're not supporting, that's when you get your prolapses. Okay, and then what happens sometimes is that urethra will start to come down, the bladder comes down, and then some urine sometimes will pool. So they peed, and then they go to stand up, and there's still a couple little trickles coming out, which can be that spasm, but it also could be that it's pooling there a little bit, and they go to stand up, and then it's running down their leg. So strengthening those, that's why we also, emphasize strengthening those muscles to support the urethra, support those vaginal walls is so important to help get rid of some of that trickling they have down their leg.
I wouldn't have thought about that, but is there anything pelvic floor physical therapy can't fix? So a good question that came in is, how many therapy sessions are usually needed to strengthen the pelvis?
So for urinary incontinence, I would say it's anywhere from 6 to 8 sessions is what we normally see our patients. If someone comes in and their strength is zero, like they don't even know how to contract them, it may be more than that. It could be 10 plus. But the norm is usually 6 to 8 sessions, because we teach patients how to first engage in positions that there's no gravity. Okay, gravity is eliminated, so they're laying down, teaching them how to engage it. It's easier to engage it laying down. Then we teach them how to engage it sitting up. So now they have to fight gravity, but they're also stable. And then we take them to the standing position where they're not as stable, but they have to really fight gravity.
And how spaced apart are those 6 to 8 sessions?
So it's one time a week for 6 to 8 weeks. And then occasionally we'll let them go for 2 weeks, see how they do on their own, do their home exercise program, bring them back and reassess, see how they're doing, how are they feeling with it. They are ready and good to go. And I'm confident, I've got it, I know how to do these exercises. Then we let them be discharged. Yep, be free, do it.
Okay. So someone's asking, can pelvic floor physical therapy improve existing prolapse?
And yes, by strengthening it may not reduce that prolapse, which is something I'm sure that the doctor will talk about, but it will definitely help to support and give that support to your urethra, to give support to the rectum, to give support to the vagina. All of those things with physical therapy will give support, so it can improve those issues that happen from a prolapse.
And I just want to add to that. So our studies have shown that it will help by 1 centimeter. So if you have a prolapse that is, outside by 1 centimeter, it certainly could take it up enough so that you can no longer feel it. So our studies will show that, it certainly helps with symptoms. And I'll generally tell patients that they should expect a 60 to 70% improvement in symptoms. That sensation of the bulge that's bothersome, pelvic floor physical therapy absolutely helps with that.
And Dr. Hudson, For audience members that might not know exactly what prolapse is, what how would someone know if they have prolapse and what's actually happening?
So most women who have prolapse will describe this sensation of a vaginal bulge. They feel like something is coming to the outside of the vagina, and there are a lot of different ways that patients describe that. The biggest thing to know is that it's just vagina. So you're never going to be seeing your bladder or your rectum, because often when your providers see you and they do that exam, they'll say things like, your bladder has dropped. And then patients come to see me and they worry that they're actually seeing their bladders, but you're not. I mean, you've got your vagina kind of relaxes over time and can kind of turn inside out. So it's all just vagina. And, just like we have babies with our vaginas and we have intercourse with the vaginas, you can push it back in. You're not going to hurt anything. It's not going to burst. There are things that we can do to help with any bothersome symptoms, but unless you're not able to empty your bladder or your bowels, it's not an emergency. It's not something to be, go to the emergency department over, if that makes sense.
The next question is the same amount of therapy sessions needed for sexual issues?
Well, unfortunately, they do take a lot longer. So doing the Kegel exercises for strengthening, that takes about 6 to 8 sessions. For somebody that's having pain with intercourse or any pain in that pelvic area, it usually, I would say on the average, about 20 sessions. That's the average that we've seen now, with also taking a look at their lumbar mobility and pelvic mobility. Sometimes we can do it in a little bit shorter time. However, when you're looking at the pelvic pain, we not only first have to address the pain, then we have to look at, well, as we're addressing that, we're looking at their posture, we're looking at strength, but we also have to look at how this is controlling it. So there is a lot that goes into it with teaching that. I've said it many times today, that relaxation, that diaphragmatic breathing, that's very important. And then we go to the biofeedback to work on the strengthening. So that's why it takes a little bit longer. So a lot of times people say, oh, there's so many people are telling me it's in my head. And I say, it's not in your head, but your head is controlling a lot of this. So it takes a lot of work on being able to, and there's a saying on my wall that says, let it go. And I say it so many times, a patient gave me that sticker to put up on the wall. So we need to teach you how to let it go and be able to get those muscles to relax, to be able to do the things that it used to do. So it takes longer than it does for just teaching how to do the Kegel exercises. And that's why. It's more complex, and there's more puzzle pieces that we have to put together and address. Because if I just had to do Kegel exercises when you're having problems with pelvic pain, you're just tightening those muscles up. Is it important to learn how to do them? Yes, but the most important part of that is the relaxation part of it when you're dealing with pelvic pain.
I thought of it. Your mantra is let it go. Dr. Hudson's is let it
Keep
flow.
it in.
No, or don't let it flow. So if someone has done therapy before, but might want to come back and learn how to use weights or some of these other cool gadgets, would that be an appropriate reason
That's definitely a great referral, is to come back. And we tell our patients too, when they're done, you're never totally done. You're always in contact with us very easily through the portal and stuff. You can ask us questions, call in to the site and ask us questions. But if they ever come to the point, we know life happens and you're doing your exercises and going along well, and something happens in your life and you're not doing the exercises like you were before, and you forget how to do them, then you can always come back for us to be able to re-teach you how to do those exercises. But just asking the doctor for a referral for physical therapy to work on strengthening is a perfect referral. Learn how to use the weights, how to use the home biofeedback units that you can purchase. All of those things we can do.
An audience member is asking for a recommended brand for the biofeedback.
Well, it totally depends on how much money you want to spend and how much, like this particular unit was like $49.99. And you can get it on Amazon. And it has a little bit of gaming in it, but just mostly things like, I think there's like a Hello Kitty that's lifting weights and going fishing to do those quick flicks and stuff. And if you're somebody that likes more like gaming stuff, then the ones that are like $199 is something more for you. So it's going to depend on how much you want to spend. Is this unit good? Absolutely. This is a perfectly fine unit. And possibly you'll be able to find one even cheaper than that, but it depends on, do you want to just be able to just feel the probe inside to be able to know that you're doing the exercises properly, or do you want to be able to actually see it and be able to do some gaming? So that's what I would say is it just depends on what you want and how much you want to spend on it.
Would it make sense for a patient to maybe come in for a consult first, and then
Yes.
you might be able to
And then
advise?
we normally will bring up the internet and show you what's out there and what's available and what each of them do. And then you can make the decision on which one you would like to purchase.
Any cushions that might keep the pelvic floor happy? I think that means
So I'm wondering if there's something more like the coccyx pain. So cushions that would, unweight that area, if that's what you're asking. There are certain cushions that we do recommend. We usually recommend one that not the donut, not the one because that seems to put more pressure in that area.
Yeah,
So if you're having,
so.
pain, you don't want to be putting that pressure there. So we usually say almost like the pillows that you wear if you're going on a flight and you want to support your neck if you're going on a long flight and stuff. That kind of cushion, just turn it around. You have the opening towards the back. So you can use that on any chair. You could take it into a restaurant. You could take it into church. You could use it, in the car, wherever you are. And that is another good thing for a referral for physical therapy so that we can talk about what would be the best option for you for whatever it is, what issue you're having.
That's a great idea.
Yeah, because posture, as I sit here slumped, posture is very important. So getting the right cushion to be able to make sure that you're in good seated posture is also important. And there's different ones you can try. And we have some there that we can try with you. And then we, again, do that same thing of looking on the internet. Here's what's available. Here's what would be best for you. And then you take it from there to be able to order it. I know that some of the pharmacies here have excellent cushions. So if they're, looking at your pharmacy and what they have available is also, they have, I know that Minix here in particular has a lot of these, the weights and the massage wands and stuff that are available.
Yes. When I took my kids for their vaccine, the
whole sexual health.
Yeah. Okay, so I think there's one more question. For those that carry stress in their pelvis, what is the best way to address this?
So obviously physical therapy, I would say, is a great way. But the deep breathing really seems to calm everything down. So doing diaphragmatic breathing, which means taking the breath in through your nose and filling up your abdomen with air, and then on the way out, like a pursed lip, like you're kissing, but just doing that diaphragmatic breathing actually causes everything to calm. So diaphragmatic breathing is a big thing to do, but then I show another technique is just a blowing. So taking your fisted hand and bringing it up to your mouth, just like as if you have one of those tiny little balloons that when you blow them up, it feels like your head's gonna like pop. So you put it in your hand up to your mouth, and just like you're blowing up one of those balloons, breathe very hard into your hand, and then you'll feel it if you try it now at home and just blow into your hand. You'll feel that pelvic floor like descend. So getting it to relax, because it's in a state of tight when you're having pain, we want it to just drop and just give and relax. So that's a good technique. Also, after somebody's had a surgery and they can't start that urination, that's a great technique to use, is that blowing into the hand to try to get them to relax that pelvic floor, or taking a cup, that one of the cups that have the lid with the straw, and just blow, you know, when we were kids, we want to do the chocolate milk or with milk and
Yeah.
make the bubbles come up over the cup. That's a great technique to use too, is just blowing those into the cup and blowing the bubbles. That also, when you do it, you will actually feel the pelvic floor relax. And it's important too to have bowel movement. So making sure that your pelvic floor is in a state of relaxation to be able to evacuate that. For someone with constipation, making sure that you're sitting in good toileting posture and doing that relaxation is key.
That's so cool.
There's lots of stuff we can do.
It's so amazing. And what a blessing that our patients have both of you as advocates and help for some of these issues. Anything I didn't mention, Dr. Hudson or Terri, that you think audience members might benefit from knowing or thinking about?
I was gonna say, I think
I could talk all night, but I think you covered quite a bit.
So I think the take-home messages are that these are pelvic floor issues that can lead to vaginal pain, painful intercourse, and incontinence are common, but with rare exception, they are treatable. And we are so fortunate to have at WellSpan great experts in the field. So I hope anyone who might be suffering at home or knows someone who is can encourage them to talk with a provider and get some help that could be life-changing. Well, thank you so much for joining us tonight.
You're
we
welcome.
are very appreciative of all the great help that you provide to our communities. And everyone at home, thank you for joining us. And I look forward to you hopefully coming back for our next menopause chat, which is going to be focusing on bone health. Have a good night, everyone.